A lot of what we're going to be talking about today are patient stories, because this is a talk about the prevention of patient harm, but also how do we respond to patient harm when it occurs. And so I begin with a very short video involving 3 sets of patients and their observations as it relates to the harm that has occurred, but also some of the responses to that harm.
If Louis had been anywhere but in the hospital, he would be alive today. He died because he was in the hospital. It was the one place we could not get him the medical attention he needed.
What happened to my daughter was the fault of the hospital.
Absolutely terrified. The doctor's telling me, my child's gonna die. That's the first moment I realized that he really hurt my son.
You feel guilty for every breath you take.
We were told he was the best neurosurgeon in the hospital. He was the only neurosurgeon in the hospital.
Worst thing that we've done in healthcare over the years is, to be honest, we've been lying to patients. We've been not telling them the truth.
If we don't talk about our mistakes, we're doomed to repeat them over and over and over again. So we have to have transparency and admit that we made a mistake in order to know what to do to try and prevent that mistake from happening again. And if we don't do that, shame upon us.
Hundreds of thousands of medical malpractice claims have been filed over the last 30 or 40 years, and yet we find ourselves in a situation where we say that American medicine is not as safe as it should be.
Why do you need a court system to tell you when you've acted badly? We know when we've acted badly.
The data is now showing that in the immediate aftermath of an adverse event, of a catastrophe, of unnecessary harm, that you can maintain trust between patients and families and care providers if you provide ongoing, honest, and effective communication with those patients and families.
We talked about what had happened and how the hospital had stepped in and acknowledged the error and everything. It was like no one could believe that. They said, that doesn't happen. The hospital doesn't do that.
I think one of the most important points that we could take around these types of cases is, while they're very unfortunate and we need to learn from them, it's also very important that we do the correct thing after the fact.
It's human to make mistakes, but it's even more important as a human to recognize mistakes have been made and be willing to change and get better.
He said, don't blame yourselves. This is our fault. This is our responsibility.
So that was 3 groups of people who've really had a huge impact on me. Helen Haskell, who lost her son, Louis Blackman, in South Carolina to significant medical errors that occurred post-surgery. And then you had Patty Skolnick with her husband, who from Colorado. And then the other couple we'll talk even more about today, which is Bob and Barb Melizzo, which is a family that I had to embrace at the University of Illinois, where their daughter suffered, as you will see, as we will share with you, a wide variety of medical mistakes that ultimately led to her demise. So the goals today are to share with you and highlight the current gap that exists between our current response to patient harm and where we could go in a more optimal state. And one of the ways we think we can get there is through this CANDOR initiative, this CANDOR project, where CANDOR is kind of an acronym that stands for Communication and Optimal Resolution, where the optimal resolution is beyond just an apology to a patient, but it's learning from these events, it's caring for the caregiver, it's supporting the whole organization through this so that you continually get better through this kind of transparency. And then finally, we'll talk about what are the next steps, but we'll talk about also what can you expect in the next few months and over the next year as we move forward. The problem is that, as we've talked about, despite many major patient safety and quality initiatives, harm from medical care remains too common. Many believe that this limited progress is due to our inability to learn from care breakdowns in an optimal way. In addition to that, our response to the injured patient and family does not reliably address their needs from their perspective. And then finally, we heard that our response to care professionals does not reliably address their needs as well. It happens on an ad hoc basis. There's times it works really well. But in terms of having a very highly reliable process to support the care professionals after these harm events, there are some opportunities, and those will be some of the tools as well as we share with you. As we all know in this room, all of you who care about patient safety, and that's why you're here, we're all aware of this important work to Err is Human, and the data from 1999 going forward continues to show we still have opportunities as it relates to harm reduction. The 2010 data from Medicare showing that 13.5% of hospitalized beneficiaries experience harm events, and that 1.5% experienced harm that led to death, and then almost half of these were deemed preventable by consensus of health professionals looking at those cases. Importantly, from my perspective, on the communication side, on the liability side, there's also other data that we need to understand and we have to embrace if we're going to move forward. And that is data that is contained in both Rosemary Gibson's book, The Wall of Silence, where she interviews bunches of families who experienced harm in the healthcare system, where they're able to share what it's like when an organization does not talk to them or does not effectively communicate after harm occurs, and how much that hurts them when that happens, independent of whether mistakes were made. But more importantly, and even from the liability standpoint, the Health Affairs article, thousands of physicians interviewed, many of whom stated that when they have difficult news to give patients or families, they are not always open or honest. And when that article came out, it's interesting how many different places the reprints of that article ended up. Now, I'm from Chicago. We do a fair amount of medical care there. We also have a fair number of attorneys. Just wondering, where do you think most of the reprints of that article could be found right now? Do you think it's at our U of I, our medical school library, or in our hospital? I see some of you shaking your head no. Can you think of some other places where you might find a bunch of them? Attorneys' offices, as she just said. So you're absolutely right. And so from a public trust standpoint, when these articles come up, it's important for us, we need to reclaim the public, the high road. We need to be seen by the media as embracing a more candid, a more open approach when these events occur, and we can do that. We can take that back, but it requires a culture change. It requires a completely different approach to harm in a way that should benefit everybody without expending a lot of resources. And again, that is the whole point of this Candor project, is how we can share tools with you to allow us to get to that next level. Because the consequences of the failed response to medical injury are significant. You have the ongoing suffering of patients and families, and that's what Rosemary Gibson talked about in the book, The Wall of Silence. And it heightens the distress of the clinicians. We know it increases the likelihood of litigation. We know communication breakdowns are a common cause where patients feel like they have to sue us to get the information. Another piece of data that came out that's very important, this was also in Health Affairs, and think about this, particularly for those of you who may be here from the legal profession. An article in Health Affairs not long ago showed that 60 to 70% of all lawsuits go away with no indemnity payment. 60 to 70% of lawsuits go away with no indemnity payment once the parties share all the information. So Candor is about sharing all the information before you get sued, so that you can prevent those lawsuits. We also believe that it's a lost opportunity for improving quality is that when these cases don't get discussed with the patients and families, and we don't get their input on what happened during these cases, we are losing opportunities to improve and get even better, particularly from their perspective. It also degrades the institutional culture or climate. People who are involved in harm events can be tormented by them, knowing that these were not particularly shared with the families, were not particularly talked about in the organization. And as we discussed, it does reduce the public trust in healthcare when the cases become known in the media where we have not done quite what we wanted to do. What do patients want? Without a doubt, again, in this program, timeliness is absolutely critical. You will see a slide a little later on where I talk about, and this is what we learned from our patient and family advisors, is that from their perspective, when serious harm occurs, every hour that goes by without effective communication is another harm. So the concept of hardwiring a slightly different approach is creating the rapid response process for harm to where you have people trained in effective communication to support the docs and support the nurses, so right away you can start the process of communication. Not to apologize, not to admit mistakes, but to reach out, establish trust, keep that line of communication open so patients and families know they're not abandoned once they know something bad may have happened to their loved one. And so the timeliness also leads to a commitment over time to tell them the truth, even though we all know, and we talked about this yesterday, what is it? Some of these cases are so complicated, we may never know what really happened. But to the extent possible, we want to share the facts with them as they know them, as we know them, and begin to share them, and in the process of that, provide emotional first aid. And again, this is the concept of the goal being when events happen, how do we hug and love our neighbors through these events, as well as the care professionals. In addition, that will involve providing empathy and compassion. Sometimes that's hard to do. What we will also be doing is helping to teach people how to have these kind of conversations, even though they may seem and may be very, very difficult. They will want their emotions recognized. They will want to be validated, even though we think their harm may not be that bad. If to them it's bad, then to them it's bad. And it's our responsibility to find ways to respond to them. And finally, what we heard about, of course, they don't want to be abandoned. They do want accountability. They do want, in a serious harm event where we know mistakes were made, they do want someone from leadership to be there with the physician or others to say, hey, we own this as an organization, and we own the improvements going forward. And that's what they want. That's what your patients want as we talk to them and how we will begin to respond to them doing this. And of course, the future prevention and appropriate remediation. So one of the questions that comes up is, and I would like to get your feel of this, as you sit there right now, what do you see as the barriers that might exist within either of your hospitals or outpatient setting to being completely honest with each other or being completely honest with patients and families? To being, especially when mistakes are made. What are some of the current fears or barriers that you have right now as you sit there? And what are they afraid of? So as you say fear, what kinds of things are people afraid of?
Retribution.
So retribution is one of the big ones, and we talked about that yesterday. So there is the fear that if it gets out, that people know that I made a mistake, that somehow, some way I might be punished. And there's shame and blame that goes along with that, where you're this person, and you've been involved in this event, and now there's a bright light shining on you related to that. And it takes a lot of courage in those circumstances to be able to step up and say, hey, here's what I saw. Here's what it is that happens. What are some of the other? Yes?
Professional reputation.
So professional reputation. And why is that important? For the physician, why is professional reputation so important?
So that, one, they can feel that their patients trust them. They don't want to lose more trust in other patients.
Sure. So part of it is a fear that could be far-reaching if their reputation is damaged, that may be bad for business. In other words, they may lose referrals. Plus, there's also the public issues that go along with that. You know, there are times when the newspapers take the opportunity to take some of these cases and shame and blame the people in the newspapers. And that can be very difficult for a physician or a nurse who's involved in that. And again, be a barrier to the ability to share this information with patients and families or with each other when these events happen. Other barriers that you can think of, particularly from the physician's perspective. What are some other barriers to us going in and admitting to patients that we may have made mistakes? So the fear of litigation. And why is being sued so bad? What are the things that go along with being sued that cause us to fear that event when that occurs?
The fear over the profession, I mean their reputation. Sure,
so the fear of reputation, once you're sued, you know, we talked about this yesterday, a lot of times, the only time you hear about a lawsuit is when it's filed. And you never hear the outcome, the fact that everybody was exonerated, but there it is in the newspaper, you were sued doing that. So certainly the reputation.
Financial impact.
So financial impact of being sued. So think about all of the financial consequences of being sued. And particularly think about it in the context of that lawsuit could have been prevented. So financial issues. You have the notice that, particularly if there's a lot of people involved, the nurses have to take off work. They have to go through a deposition. The docs have to take off work. They have to go through a deposition. I can tell you, having gone through a deposition, it is one of the most gut-wrenching, emotionally traumatizing things that you could ever possibly imagine. You know, and it's part of that. It's kind of a fantasy in a way. You know, you raise your right hand, now you have to tell the truth. And in Illinois, you can expect almost any question. So depositions, they're costly emotionally, but they're also costly financially because you got to take off work, you got to have somebody cover it and do the rest of that. The other financial pieces of it, and this is what really drove Nikki Centomani, our Director of Safety and Risk Management, to begin to look at some of these cases. We identified in 2002 and 2003, we were spending hundreds of thousands of dollars on terrific defense attorneys to defend the indefensible, though. So we had cases we knew we were going to settle, but we would spend 3 or 4 or 5 years, hundreds of thousands of dollars, and selling for millions anyway. And thought there's got to be a more financially efficient way to begin to do that. So the financial impact of doing this can be huge when you're sued. And it goes just beyond if you make a payout or what have you, and there's also the emotional turmoil that goes along with it.
Destroy your career because some of them become uninsurable.
Sure. So the other part is it can have a huge impact on your career as it relates to that as well, and then perhaps maybe you're not insurable as well. And then in the back.
Excellent conversation so far. I wouldn't underestimate the emotional impact on us as healthcare providers. When we take care of people, we do it with our whole heart and soul. And so when we make a mistake, that ability to admit a mistake, very, very difficult because it gets to our very identity as individuals. So you mentioned the emotional turmoil. I've seen many colleagues be absolutely distraught at even when they haven't made a mistake, at the fact that harm had happened on their watch. So I think that one of the barriers that really needs to be emphasized is this barrier of ourselves, and our own identity, and how to take care of ourselves as we are honest with our patients.
Completely agree with you. A fantastic comment. And it leads into something that we discovered in our demonstration grants on this outreach to patients and families and communication. What we found was, particularly with the physicians, when we would do our training session around how to provide care for the caregiver, how to provide a reliable care process for physicians, it was amazing the interest that all the physicians had in that. In fact, when we then surveyed at the end of our grant the things that they found most valuable, 3 to 1, the physicians wanted a hardwired process where they could get support in a non-punitive way, in a way that's not controlled by the corrective action arm, but a place where they can go to have that kind of support and take them through that. Well, the neat thing about this, and what ARC is funding and HRET is helping us establish, the Care for the Caregiver program that we will be helping to hardwire here will be very comprehensive and will involve support of everybody, transporters, cafeteria people, nurses, pharmacists, physicians, everybody. And we're very excited to be able to bring some of those absolute best practices here to do that. Well, obviously, I'm not here unless there's some benefits. Otherwise, we'd just kind of be doing it the old way. So there's got to be a few benefits related to this. So what can you think are some of the benefits to being open and honest and meeting with patients and families and trying to resolve these events earlier instead of the more traditional way? What are some potential benefits, if any?
Peace of mind.
So peace of mind for who?
For all parties involved.
So everybody. So patients and families, but also the care professionals. Mm-hmm. The emotional well-being of everybody, including the employees, you can actually track. When these kind of programs get implemented, employee satisfaction goes up, in addition to HCAHPS scores. So it is both sides is what you're looking at here in terms of people's satisfaction after these events occur. Very good point.
If there are system issues that allowed the mistake to happen and there's something you can do to correct that system issue, you can prevent the harm down the road.
Absolutely, completely agree. And that's why you saw in the video Bob Galbraith, who formerly from the National Board of Medical Examiners, makes that comment about transparency and the need to learn from these. So it's our belief that the candor process, one of the primary outputs is what you just said, which is an opportunity to identify systems issues that spread across the organization with some of these events. And again, that is going to be one of the important tools that we bring forward to you. But completely agree, that's one of the massive benefits of this kind of program. Yes?
I guess my other comment would be that it needs to be timely. So it needs to occur when the event occurs, and there shouldn't be a big time lapse between the apology and the event.
I completely agree, and you'll see me reiterate that in a couple of slides, but the timeliness is critical. Although it may be good to reach out to the family in 6 months, if you've not talked to them in that 6-month period of time, the likelihood that you've lost trust is pretty high. And so that is another piece of this. The unique part of this is the really rapid response by the organization to understand what happened and connect at the same time, begin communicating. Again, not the apology right away, but just begin that process of communication.
Yeah, I think another thing that it does, it aligns the organization's values with its actions. It creates a culture where we are doing what we say we value.
Absolutely, and so every day you come into work, you will know you're coming into an organization that supports this approach. And for me, that is a really important feature as it relates to having that joy when you come into work, knowing that there is meaning to what it is that you do. And I think it's a potential huge solution to the feelings of burnout that a lot of people have when they're in an organization and you see harm every day. At least if you know there's a principled approach to it, it can bring much more joy and meaning to that. Obviously, the other benefits that we've seen, and I can tell you it's staggering, is on the financial side. When we looked at this in 2010, our cost of our medical liability program in the entire state health system for the U of I was $44 million a year. And we had already had a very active process, claims were going down, but then they continued to go down to where this year, our premium that used to be $44 million is $19 million. It's $25 million less in 4 years. And when compared to other organizations in our area, other academic institutions, it's a much steeper drop than any of them, and it is normalized for patient contact that we have. So staggering dollars have been saved by doing that, which again flies in the face of what people originally thought, which is you're honest with patients and you tell them about mistakes, you're going to see claims go up, you're going to see costs go up, and the rest of it. We have not seen that. It is not the financial Armageddon that a lot of people predicted would happen. And so the benefits clearly seem to us to outweigh the barriers. The programs were put into place, as you've heard about, and it led us to the opportunity to deal with a particular case, and this is an opportunity to share with you a case we had at the U of I that we know a lot about how the Candor program made a huge difference to the organization, to the care professionals, but also to the family who is involved. And this is the case of Michelle, who was a 39-year-old woman who came to our hospital to have a procedure redone that could not be completed because she was so uncomfortable during the first procedure, was rescheduled to have the case done by folks in my department, in the anesthesia department, but unfortunately, as often happens, the procedure list was delayed and didn't get to the procedure area until 4 o'clock in the afternoon, at which time those of us in anesthesia said, hey, we're off to the OR, we can only cover emergencies. And so, unfortunately, at this time, the resident goes to Michelle and says, you know, I know you woke up the last time, you were uncomfortable during the procedure, but I promise we will give you more medication this time. I promise you, you won't wake up. And that was communicated to her in front of her parents. Now, based on that, she decided to go ahead and proceed with the procedure. And the standard monitors were used. As you can imagine, this is a case. It's in a dark room. She's turned on her side. From the nurse's perspective, you know, you can't reach the chest to listen to breath sounds with a stethoscope. They're focusing on a complicated procedure. Everybody is looking at the diagnostic monitors. The physician asks the nurse to leave the room to go get another device. And when she comes back, she notices Michelle shaking, the whole bed shaking. She turns the lights on and sees that Michelle is seizing and is blue. And a code is called. They give her the reversal agents, flumazenil and Narcan. She doesn't wake up. Eventually, they get her heart and her blood pressure started. And the assumption at that point in time, since it seemed to be out of the blue, is that she had suffered an allergic reaction to the medication. Fortunately, 5 minutes into the code, our Director of Safety and Risk Management gets notified. This is that hotline response. This is a bad event. You need to get here right away. This is going to be difficult. This is going to be complicated. And the Candor approach is what we hope to hardwire in all organizations so that your response can be similar to the kind of response that was able to be provided in this particular case. And so what is Candor? Well, it's a federally funded initiative that integrates best practices from pioneering institutions for responding to harm. You have the University of Illinois' work, which we adopted a lot from University of Michigan, University of Washington. We have people from Harvard School of Public Health. We've had input from Stanford, from Vanderbilt, from all over these best practices of what are the best ways to respond to the kind of event where I've just set the scenario for you. The first steps are actually the gap analysis and the organizational change readiness. And those are things we've actually already done here at ChristianaCare, or we're almost done. We have done the change readiness. This was a survey that was sent out to various key stakeholders in the organization, just asking the question, are you ready to hardwire all of these processes? The immediate response to harm, the communication, the optimal resolution, the focus on systems for improvement. That was in the change readiness questionnaire. We have that data. Soon that will be coming back to the leadership here as well. And it is a self-evaluation to sort of do that. And then in addition is the gap analysis, where we do these key informant interviews with various leaders and frontline staff. And we find that out in the gap analysis, where we meet all kinds of different people at all different levels. And sure, there's gaps and there's opportunities, but there's also a lot of things at ChristianaCare to shine that bright light on. So moving forward a little bit further, the other piece is incident reporting. But more importantly, and where one of the opportunities are, and as she mentioned there, the timeliness piece, you've got to make sure you have a reliable process. So when you have a case like Michelle, somebody can pick up a phone and immediately get a hold of somebody who is trained in how to immediately respond to this stuff. Because I can tell you, in Michelle's case, that nurse, once that patient was resuscitated, the nurse ran out of that room and never came back again. Ever. Never came back to the hospital again. And we needed to get there right away. And it's really critical when we get into the investigation of the case that you do have this sort of rapid response to get in there for lots of reasons, not the least of which is that's where a lot of the data is going to be early on that may not be there in the next day or two. And so getting in that room and being there to get the fresh reflections of the people involved in that is absolutely critical. And this reporting is an important measure of culture. The next section is event analysis and process improvement. And this is one where we look at the best practices around how do you look at these cases in a way where it's a safe zone where you do it. Whether it's the debriefing that you do, whether it's the root cause analysis that you do, but to do it in a timely way where you follow a just culture approach, which it does seem has been a big movement that you've had over the last couple years, particularly since I've been here, and is really starting to get traction. Because when you look at the traditional approach of who's to blame, a lot of people will go right to the nurse or right to the doc who ordered it, or maybe even the anesthesia department for not providing support or what have you. But a just culture approach would really look at systems related to what happened, and that is something that we were able to do in this case. The just culture, as you all know, distinguishes between human error and then at-risk or reckless behavior. And I know this is nothing new to you all here at Christiana Care because there's been a big movement afoot to make sure that people understand this. And importantly, as James Reason talks about, I just love this quote, fallibility is part of the human condition. We cannot change the human condition, but we can change the conditions under which people work. And so when you get into the systems approach, it's recognizing that that book was right. To err is human, and we're still going to have humans taking care of patients, which is to say mistakes are always going to happen. The question is, how do we design our care to catch those mistakes? And so the notion here is to try to identify what is responsible, not who is responsible. And we heard a lot from people yesterday that you would like and you're very interested in the tools that we're going to be bringing to you about how to use human factors analysis on your harm events so you can really help redesign what it is that's going on. And we're going to be working with some really, really smart people throughout the country who are incredibly knowledgeable in human factors to bring that forward. Where what we do is we don't look at redesigning people, which is to say you almost never want to see your action plan to be one of two things, education or counseling. Education or counseling, you may need to do it. Joint Commission will kind of like it. Check the box, go forward. Sustainability, keeping, change, not likely to happen if it's only education and counseling. It's where you need to think about redesigning the system within which these people work. And the other piece, critical, and we talked again to your patient advisors about this yesterday. And in the Melizos case, really important to get their perspective on these harm events. And then even when you come up with process improvements, engage the patient, engage the families. Getting back again to the culture of candor, the C in candor is communication. And after event reporting, there are important conversations to have with the patients, the families, but also the caregivers. What we know, not everyone is a good communicator. In fact, you may know people in your organization who are not particularly good communicators. In fact, you may see them on the other end of the spectrum. They may have that unique ability to kind of upset a lot of people they encounter throughout their daily work or when they go to McDonald's or somebody else. There are special people who are like that you need to understand. When they're involved in a harm event, it's kind of nice to balance them with one of your good communicators. And so we actually have an assessment tool that in part assesses emotional intelligence and cognitive complexity that will help your organization identify who are potentially your best communicators to become part of this process. We've done it on hundreds and hundreds of people so far, and it's staggering to see the outcome and how well you can train some of these really great communicators. Then we will be going through this opportunity to train people to help them handle these emotionally difficult situations and to deal with some of the events that occur that don't quite go the way that we'd like them to. So here's an example where there may be a little bit of benefit from communication coaching and preparation before we have a conversation after a mistake.
I hear you had a rough night. How you feeling? A lot better. I blacked out and woke up in the ICU. I had no idea I was so sick.
Well, let me tell you what happened. As you know, diabetes produces wide swings in your blood sugar levels. Last night, your blood sugar dropped down to 35.
35? It's never been that low before.
Yeah, that's dangerously low, and that's why you passed out. But we were able to get it back into your normal range, and you should be okay from here on out.
So why did my blood sugar drop so low?
I'm fairly positive it was a bad reaction to the insulin you got last night. We've adjusted the dose somewhat, and this shouldn't happen again.
Bad reaction. Is this insulin different than what I usually take?
Oh, no, it's the same stuff, but it looks like you got a little bit more insulin than usual. So now that we know how much you actually need, this isn't likely to happen again. I'm glad you're feeling better.
Wait. You know how much insulin I need. I've been taking 10 units for 4 years. Why would you change it? And exactly how much did I get?
Well, looks like the nurse gave you 100 units.
100 units? You can't be serious.
Look, I understand you're upset, Mr. Thompson, but there's no reason to yell. There was no permanent harm.
That's good. See you later.
You're in no condition to leave just yet. I mean, this is just a bump on the road. Things like this happen on occasion.
So there are lessons to be learned in how to communicate, as you can see from that video. And our communication tools we'll be sharing with you will include the use of standardized patients in a variety of scenarios so people can practice having some of the most difficult conversations. But as you can see, that kind of attempt at disclosure is all too common. And we have seen that in a lot of our grant hospitals, where a whole lot of things happen related to the fear that people have, and it even fits to the article that we were looking at in Health Affairs about not always being honest. So getting back again to step one on the communication, as we mentioned, after serious harm, every hour that goes by is another harm. So it's important to have a very rapid response to that. And then the various kinds of steps that we will take you through and make sure that you've hardwired as it relates to take advantage of those debriefs you do here and those post-event huddles so that you're able to communicate in a consistent way, and then talk about the plan for investigation and getting leadership involved. These are all extremely critical areas. We know we're not doing as well as we would like to. When you talk about some of the data and you compare the physicians, their perception of how they did, they think they did really well, but when you actually interview the patients, not so well. And so part of what it is to help people really appreciate what are the needs of the patient, how can we, in a more effective way, provide these kinds of disclosure conversations going forward. And some of them are incredibly important. One in particular that we had that shows you the importance of knowing who your really good communicators are is we had an OB case which at 4 o'clock in the morning, we handed a baby to the wrong mom. And she breastfed that baby. And at 5 a.m., the lights got turned on, and she and her husband recognized immediately that could not be their baby. And that caused angst. And fortunately, the nurse who went in the room did what they're supposed to, which is call the hotline. So they get a hold of our safety risk manager on call, who calls me, and then we immediately need to identify, well, what is our situation in this case? Who do we have who's in-house, who's going to need to have 2 rapid communications, right? Because one is you got to talk to the woman who breastfed the baby, but the other is the woman whose baby was breastfed. And when we looked at who they were, the person on call for OB was kind of special in the communication domain, if you know what I mean. But on the other hand, the guy on for family medicine had scored one of the best scores in our communication, our EI assessment. And he was in-house, which is like eureka. So I call him up on the phone. I said, you need to go in there and you need to talk to both these moms and explain the stuff. And oh, by the way, giving a couple weeks of diapers, all sorts of other stuff. It's really important. We are counting on you. If you mess this up, we are all in big trouble. So he said, no problem. He goes in, he has this conversation, and he is such an effective communicator, as a lot of family medicine people are. Learned that yesterday. Unbelievably cool family medicine people that you have. I can see them easily being part of your team here. But anyway, by the time he's done communicating to them, they literally are thanking him for the opportunity to kind of engage in this wet nurse process that happens millions of times throughout the year, to no harm to anybody. There were no infectious disease issues. He was completely able to de-escalate it for both of them. No press, no other stuff related to that. And it was really important for the unit and the organization. Clearly, we needed to provide care for the caregiver. There are whole crazy systems issues about how that ended up happening. But more importantly, to the concept of paying it forward and changing the culture and changing medicine for good was what happened 3 years later. So Dave Mayer and I were doing this talk to the first-year medical students at the University of Illinois, largest medical school in the country, 350 students per year. So anyway, we're doing this talk to the medical students, and when we're done, this woman walks up to us, and she starts to cry and says, you probably don't know who I am, but I'm the woman whose baby was breastfed at 4 o'clock in the morning. And I can tell you that the communication as you described by Dr. Potter was, as you said it was. It was so empathetic, it was so compassionate, it handled what otherwise would have been a horrible situation. So when I had my choices of medical schools to go to in the country, I chose the U of I, because I want to be part of one of these disclosure coaches. I want to be on this communication consult team. I want to teach my fellow medical students the importance of this kind of communication. And when I become a doctor, if I do, I want to teach my fellow physicians the importance of this. And so unexpected things happen when you do things for your neighbor. And you know that as well, taking care of your neighbors at Christiana Care. And so when you have these events, just continue to keep in mind, they're your neighbors. And what goes around, comes around. And in very unique and incredible ways. The caring for the caregiver, we've talked about, again, the importance of this throughout my talk, that we know medical error increases if we don't provide care for the caregiver. Burnout, risk of suicide, we've all seen the horrendous outcomes related to this. On the resolution side, the other piece here, as that patients will share with us a lot, is that sorry doesn't work alone. And that you can even imagine in our case with Michelle, with a 1-year-old and a 7-year-old. She's now had a cardiac arrest. She's in the ICU right now. We're now beginning to learn information that she's likely not going to wake up. It's going to take more than an apology to make that family whole. And we need to think about how do we make sure that we handle some of these conversations. We know that one of the things that will clearly lead to litigation is after a harm event, when we know we've done inappropriate care, if we bill that patient and we send them to collections, that's just not a good risk management strategy. We did that with a wrong-sided neurosurgery case. So we operate on the wrong side of a brain of a patient. The system didn't find out about it well enough. We sent them bills, and then we sent them to collections. So that did not reflect well on the reputation of the organization. So you do have systems in place here where you are able to, in a lot of cases, it's kind of ad hoc, hold both the professional fees and the hospital fees, but that's, again, something that we will want to work with you and then figure out ways to come to an even more important resolution related to that. And so back to the Malizo case, to Michelle. So she does end up in our intensive care unit, and she is not responsive, as I mentioned, to reversal agents. And our investigation reveals that when we arrived in the room where the procedure occurred, there was documentation in the trash that was not in the official medical record that indicated that she had gone 7 minutes with an oxygen saturation less than 50. That was not in our medical record. Our peer review of the medical record said care was appropriate, and this must have been an allergic reaction. until we shared with them these strips that we had found that were clearly her strips that weren't part of the official medical record. And so now you have one of those really unique situations, which is, do you now share information that the patient otherwise would have zero access to that shows you made a mistake that has resulted in very serious harm? And fortunately, at that time, our candor process was well hardwired. And so when we went to the leadership of the university, we went to the board, their answer was an obvious, well, of course you have to share it. And so we had the opportunity to go in and share with the family and explain to them that Michelle was now brain dead because of mistakes that we had made. And we embraced that family during that period of time and then continued to stay in contact with them because, again, disclosure is a process, it's not an event. We continued to stay in communication with them. We did go to the funeral. The remediation in this case occurred in less than 6 months. There was no lawsuit filed. There were no legal costs associated with it. No one was reported to the data bank because there was no formal claim filed. And we met with them a year later, and they said something that was very important, is when you want to reach out to patients and families and have them engage in your patient safety efforts, it's good to get by the firsts before you reach out to them again. The first Mother's Day, the first birthday, the first Christmas. So we let all those go by. We reached out again, and they came up to us and said, thank you so much for staying in contact. You have no idea how much you reaching out to us has helped us heal from this. We're still angry. We're still upset. We still miss Michelle. But we know what you did was a very courageous thing and helpful for us. And we know you were too generous, so we want to give back to the patient safety program. And we would like to be part of the process improvements. So we were able to get Bob and Barb and Chrissy permanent seats on our medical staff review board, which is our board that reviews all our serious safety events, as the conscience of the community to remind us of what we're trying to do. And the follow-up for this, the pay it forward piece with this is, Bob actually gave a speech at one of the quality meetings that was on YouTube. And by this time, the 7-year-old was 11 and saw Bob give his speech related to them stepping in and helping the University of Illinois, where her mom died. And after she saw this on YouTube, she turned to her grandpa and said, do you think the University of Illinois will let me join that group so I can help them when I get older? That's your neighbor. That is what we're looking for in this culture change in doing that. And so, as you can see, going forward, there are these opportunities. That's Chrissy and Bob at our medical staff review board meetings. Fantastic, terrific people. And there were a lot of systems changes that occurred after this that went beyond just the U of I, but throughout the country. We realized then that we needed to immediately begin using capnography, particularly in these deep sedation cases, and to learn to titrate sedation to the respiratory rate. So we weren't just giving it blindly and hoping that we were hitting it right. And we know, auditing our data, that has made a huge influence. And it then became, in part because of this case, but many others, a guideline put in place by the American Society of Anesthesiologists, which the Melizos are so proud of and so happy that they were part of making that significant substantive change that involves human factors. And then independently, we did a lot of other important stuff related to that. But again, paying it forward, and the unexpected things that you see might happen is that when Michelle was brain dead in the intensive care unit, she was a healthy outpatient who'd now died, which in Cook County is a coroner's case. And a coroner's case means they have to do a complete autopsy, which is to say they need all the organs, and so organ donation is not a possibility. But being an attorney, I say, look, would you talk to Bob? because he'll tell you, we've already been totally honest, they are not going to have to litigate this. And so Bob talked to the coroner, when the coroner is then able to allow those organs to be direct donated, in fact. So the kidney, as it turns out, you know, Bob's got a friend, as you can see in the picture there. In fact, it's more than a friend, it's his best friend, who is the chief of police, where he was a former mayor in Hobart, Indiana, who'd been on dialysis forever, who was about to lose access. And so he calls his friend. The first thing his friend says is, "I am so sorry, Bob, for your loss." And Bob says, "My loss may be your gain. What's your blood type?" Turned out to be an ideal match. So he was able to direct donate his daughter's kidney to his best friend, who was the chief of police, where he's a former mayor, who's out of the hospital in time to attend her funeral. And it keeps going, because a year later, Barb, Michelle's mom, walks into the Department of Motor Vehicles in Hobart and gets a standing ovation. She's like, "What is this?" And she said, "You can't imagine. When that newspaper article hit the Hobart Press and they saw what you did and the courage you had, the number of people signing up to be organ donors went up 500%. We're a model in the entire state of Indiana for increasing the number of people who want to be organ donors." They hugging, cheering, all that sort of stuff. So it's an amazing story to see what can happen when we're candid with our patients. Willing to answer any questions that any of you might have related to candor.
Do you have comments about how to engage the insurance industry, who often, too often, counsels physicians and others to be quiet in their conversations with people who have been hurt and their families, rather than absolutely candid? Yeah.
So the question is how do we work with and how do we deal with the legal community, you know, who for years has kind of taken that position of when harm occurs is not talk about it, you know, not even get emotional support, you know, for what it is that you're going through. Very, very common. So several things kind of related to that. The first is that when we applied for our demonstration grant in Illinois, I needed to get our med-mal insurance carrier for almost all the physicians to buy into this. All the way up to the tougher part that we haven't totally figured out, which is, okay, there's a harm event. How is it going to happen in that room? It's kind of like sausage making, where people decide who's going to pay what. But at least they were committed to rapid communication and open communication with patients and families. Well, following that, we have reached out to a lot of other insurance companies who actually are beginning to see so much of our data that they now see it not as just the right thing to do, but the financially smart thing to do. So an example would be the Doctors Company. The Doctors Company out of California insures 110,000 private physicians throughout the country, is a supporter of candor. In fact, if you go to their website, you will see 3-minute snippets of this kind of talk, that they're having their physicians view. It's a new day. And they're working with their defense counsel to make sure they know it's a different day, that we need to begin to focus more on this kind of communication. So then the other group we've worked with tend to be the reinsurers. So the Zurichs and the AIGs and the others that insure the hospitals. And to the extent I can see with that, they are really coming on board because they're already seeing for the hospitals a huge reduction, particularly in their big cases. So it's kind of a long-winded way of getting at the fact we need to get these stakeholders all together. The one thing you didn't mention, which we have not cracked this problem, and I bring it up now, I thought it might come up a little bit in the discussion where he said the barriers. State licensing board and the National Practitioner Data Bank is a massive issue, particularly for the physicians who are not employed, who are the private ones, where if their insurance company does make a payment, there can be that requirement to report to the National Data Bank and into the State Licensing Board, and that is not fun. That can be tormenting as well. So there are programs we have that are sort of related to that, but to that extent also, we're also working at the policy level. That's why I'm really glad that Senator Carper's staff is here, because they're interested in this too, is is how do we create the public policy that encourages candor and gets away from the deny, the defend, and the shame and blame, while in the meantime, as you all know, how do we hold the reckless accountable? Because that's what the public's afraid of, is that if we get rid of the whole national data bank completely, how are we going to make sure we have at least something in place for them to identify those who may behave recklessly? So that's a lot of stuff happening. We totally realize we have to have them on board to succeed. There's just no doubt about it. In fact, we could not run our U of I program until legal got on board. There's a little aside to that, though, and from the defense attorney standpoint, is when the U of I took this forward, we had a plan of we needed to identify who were those outside law firms we were going to hire to represent our docs when these kind of events happen, because again, we're all self-insured. So we interviewed 15 defense law firms, and this was in 2005, I think it was, because we were getting ready to launch the program. And so we interviewed these 15 law firms, and we asked them all the same hypothetical. We just cut off the wrong leg in operating room 1, and we know for sure that we did it. We're now calling to ask you for advice. What do you recommend? And we were looking to identify those law firms willing to say, that's the kind of case that you best put into alternative dispute resolution right away. It's not going to serve anybody well, if the facts are absolutely crystal clear, to defend that. So we asked them what their position was. How many of those law firms do you think took the position that, you know, this is the kind of case where you want to reach out to the family, you're going to want to mediate this, you're going to want to resolve early? How many do you think? Two. Turns out it was 3. And one firm in particular, one of the people said, you know, I've had one of these kinds of cases, and we're pretty good at finding reasons in the chart. It was okay to cut that leg off. So a long-winded answer to your question, but the legal piece is critical for addressing that. Yes, sir. Hang on just a second so they get your, there you go.
So here's the question about the incident reporting. And say you identify a problem you have, and perhaps could be the left leg versus the right leg. We know we have checklists, we know we have doubles, right? And still this event occurs, and the problem is that not because you have a checklist and you have 2 people checking, it just the events that occurred for that particular patient were very different or not standard to what the other patients or cases had occurred or has in the past. So sometimes, how do you solve that issue? Like,
right. So part of the tool we'll bring you related to that is a whole different way to look at those events, kind of different than we used to before, which is really try to understand how the work is actually done in that area, to then put things in place like the shutoff valve for the gas or the other piece, knowing those things will still happen. Get a bunch of really smart people together to think about how do we redesign this in such a way where it catches it before it hurts the patient, knowing that there's going to be mistakes that are done doing that. And there are people doing some really clever stuff out there, and I don't even pretend to know all what it is. But I can promise you, if the only response to the wrong site surgery is education and counseling, the likelihood of it happening again is about 100%. Right. Because to err is human. And you can keep educating humans, and it's amazing. They stay human. They may not feel human. No, they may not feel human, but they stay human, which is to say they may make a mistake down there. So how do we redesign that? And that's the challenge. And thank you all for caring. Thank you for caring about patient safety.